Hello friends, in continuation to my earlier talks on CHYLURIA, in this video I shall talk to you about the third aspect of this disease, which is how is the CHYLURIA diagnosed. First of all, you should know that a patient of CHYLURIA can present to many specialists depending upon what is the type of urine he is passing. If he has a very mild chyluria and urine has only some degree of albumin in it, then patient is regarded as having proteinuria, albuminuria. People often miss to diagnose the presence of lipids and cholesterol in urine, just focus on protein part of it. And the patient goes to a nephrologist. When patients pass a whitish urine, it is often seen as pus in urine without fever, sterile pyuria or something like that. And then often I have seen them being diagnosed as tuberculosis by tuberculosis physicians. When they have a red urine, which is dominantly blood in it, and they are labeled as having hematuria with clots, and then patient goes to oncologist with the fear of diagnosis of cancer in the urinary bladder. When patient passes whitish urine and these episodes keep happening to him and no diagnosis is made, then patients often go to alternative medicine physicians for Ayurveda treatment, homeopathic treatment, because they feel they are suffering from some incurable disease. It is only when the whitish urine forms clots and clots start obstructing the bladder outlet, the patients come to a urologist. So to us. So you would see here that the chyluria patient can go anywhere depending upon the severity of presentation. So how to diagnose chyluria is a useful piece of information for each and every person who is practicing medicine. The first step of making a diagnosis would therefore be when patient says I am passing milky urine, that you confirm that the patient is having chyluria and not other things manifesting as whitish urine. This is what is the classical appearance. Patient will give a typical history that whenever I consume a fatty diet, after about hour or two of that, my urine becomes milky white, turbid, like this. So when you have this combo, a typical history, patient will say sometimes I was doing bicycling or training a bit, lifting weight, and suddenly started having chyluria. Or in ladies, pregnancy is a state which often initiates chyluria because pregnancy leads to enhancement in the lymphatic flow and compression on the lymphatics in the peritoneum. So this is how the thing happens. The problem happens when the patient has mild and intermittent chyluria or they have blood in urine, some kind of the urine will look like that. Now here is the diagnosis often missed and a wrong diagnosis is made. If they are labeled as UTI or tuberculosis of genital urinary tract, leakage of semen in the urine, or even if they find hematuria very severe, patients are diagnosed as cancer urinary bladder because there is a clot in the urinary bladder. So if you have to diagnose chyluria, the sheet anchor of diagnosis making is a study on the urine, right? Urinary studies. And you have to know that the patient is passing chyle. So you can test for the chyle, first of all. Then patient is passing proteins, albumin and globulins. Patient is passing lipids, triglycerides and cholesterol. And patient is passing lymphocytes. So you can measure each and every part of this in the urine in the patient. We consider in terms of the importance, presence of lymphocytes, sine qua non, most important feature of chyluria. Then lipids, presence of triglycerides of any amount in urine is considered important. Or cholesterol, any amount of cholesterol in the urine should be considered as suspicious of chyluria. If it is more than 15 milligram, then it is considered diagnostic of CHYLURIA. So you have these chemicals, biochemicals coming in the urine. How do you actually go about? The first test to be performed in these patients is the ether test for chyle in the urine. Ask the patient to bring the urine sample to you in a test tube, and you do what? This is the fasting urine sample, and this is urine sample after fatty meal. This is you collect in the two test tubes. In this test tube, add some drops of ether, and because there's a chyle and there's a fat in it, the ether will start dissolving the fat within 2 minutes. And after some more time, 5 minutes, you will see it becoming clear. Not as clear as this, but more clear than what it was here. So this loss of turbidity with the addition of ether shows that there is a fat content in the urine. Classical test known to us from ages. Then when patients have milky white urine, we will feel it is CHYLURIA, but let's not close eyes and let's not forget two more common differential diagnoses. One is phosphaturia and other is pyuria. In this patient pass phosphate crystals in urine, and in this patient pass pus cells or frank pus in urine. The phosphaturia is more crystalline looking, not like clear of chyle. It's more crystalline looking. You can shake the urine sample, you can see crystals floating in it. And when you add acetic acid, the phosphaturia will clear. In the same manner, the pyuria means the patient is passing pus cells and neutrophils in urine. But in CHYLURIA, patient is passing chyle in urine, and what test we consider important? We will do ether test or chloroform test. People have done in past Sudan 3 test. Patient was given to eat, Sudan stained fat. This was in earlier times. We don't do this anymore. Patient was given Sudan 3 labeled fat to eat, and then it will come in the urine, and patient will pass pinkish white urine. We demonstrate lymphocytes in urine by methylene blue test, and then we demonstrate urine triglycerides more than 15 milligram per deciliter. And if this is how 1, 2, 3, 4, we confirm that patient is having CHYLURIA, not phosphaturia or not pyuria. So it's a pretty simple. Some patients have hematochyluriac, and depending upon the quantum of chylous clot and the blood clot, it forms a heterogeneous clot in the urinary bladder. And on ultrasound, these patients are often reported as having bladder cancer. Very, very common mistake and blunder, I would say. And we described a new sign for the diagnosis of this kind of clot. We did ultrasound of these patients, and we noted what is the difference in the SOL caused by bladder cancer and SOL caused by hematochylous clot, right? So we observed that in the hematochylous clot, there's a lipid in between and there's blood around. So the difference in the ultrasonic impedance, there's a difference in the blood and the lipid. So the clot looks like as if there are vacuoles in the clot. And we describe this sign as vacuolation of the clot, or you may say heterogeneity of the SOL that you see in the bladder, and it is usually lying in the dependent part of the urinary bladder. So we published this information long time back in 1998. The second step of diagnosis is, having known that the patient has CHYLURIA for sure, you move to next step, and that is quantify the severity of CHYLURIA. This is done by the grading of CHYLURIA. And there's a recent publication on this in 2020, where the authors have put in a grading system, which is an objective grading system. And for that, they have considered clinical features and retrograde study. I'll talk about this later. But just I'm bringing in this information on the basis of retrograde pyelogram. What do they see in that? They have started grading the chyluria, and this is mild chyluria, intermittent episodes of milky urine, and when retrograde study was done, involvement of only single calyx. Then they said moderate chyluria if there are intermittent episodes of milky urine plus clot colic. Clot colic, because when the chylous clot descends down the ureter, patient can have pain. And then involvement of 2 or more calyces on retrograde study. Then they said severe chyluria, where patient has not only milky urine, but he develops either urinary retention because of the clot, hematochyluriaor systemic symptoms like weight loss. So obviously it is more severe in terms of the manifestations. And then on retrograde pyelogram, they demonstrated involvement of most of the calyces with possible ureteric involvement. Now this is one way of grading it. My feeling is that when you do a retrograde pyelogram of these patients, you will not always see the fistulous communication, first of all. So if you don't see a fistulous communication, in which grade do you put them? And secondly, I have noted that in those individuals who have very, very severe chyluria, it is often seen that there is no pyrolymphatic fistula demonstrated in retrograde pyelogram. So I don't think that the more is the number of calyces shown involved in retrograde study, this is parallel to the severity of chyluria. From our institution, we published a paper some time back. This was factors affecting response to medical therapy, and we have created our own grading system. And this was considering chyluria episodes and considering presence of blood. Grade 1, where chyluria episode is single per year, only once in a year. And then hematuria is less than 1 episode in a day, only 1 episode. Then grade 2, when chyluria episodes remain the same, but the blood episodes increase little more. And grade 3, when chyluria episodes become more than 2, and the blood episodes also become more than 2. Now, in this grading system, we have given more emphasis to the blood part in the chyluria, which is also another way of looking at it. But my feeling is that it is not that you have to grade the severity of chyluria in the entire spectrum of the disease in 1 year or in 6 months' time. Each episode the patient has, that should be graded, and therefore the mild chyluria should be when patient passing mildly turbid white urine, and this turbidity in the day fluctuates. Sometimes becomes more clear, sometimes becomes more milky. So the turbidity is mild and it is fluctuating in severity. It is called mild chyluria. When urine becomes more milky, more thick, more white, and the same degree of turbidity persists throughout the day, then I call this as moderate chyluria. And if patient has any of these 4 or more of these 4, thick milky urine, which is persistently going on, passing curd-like clots or passing blood clots in urine, or has developed urinary retention due to clots, or has developed severe nutritional effects as a result of persistent fat loss from the body, this I consider severe. So the grading of chyluria should be not grading the disease over a period of 6 months. I think each episode of chyluria should be graded and be treated accordingly. Moving to step 3, lateralize the side of chyluria. Chyluria, as I said, often happens from one side. It is more common to have unilateral. Often it is left side. But then you cannot presume it. It can happen on the left, it can happen on the right. And you have to decide from which side the chyluria is taking place. For that, the simplest test for us is to do a cystoscopy and a retrograde pyelogram after a fatty meal. In this patient, you will see that a jet of whitish urine is coming out, and you can look at the degree of turbidity of the jet. You can look at the turbidity of the jet. Here it is not very turbid. Here is another patient of chyluria, and you look at the efflux that is coming out. It is coming in form of blobs. It is more whitish. It is more thick, more dense. So by looking at the ureteric orifices cystoscopically, you can not only say from which side it is coming, right or left, but you can also say how bad it is, how thick it is. Now, when you see cystoscopically, you will see a chylous hue in the urine in the bladder. And then you go to ureteric orifice, you will see the chyle is pouring out from one orifice, and you will think that I have diagnosed it is on the left side. But please, for God's sake, look at both the orifices with patience. Sometimes, like here, you will notice chyle coming from right side also. So it is a case of chyluria where chyle is pouring out from both sides. This is rare, I must confess, but it can happen. So please examine both the ureteric orifices patiently. Guided by the cystoscopic appearances of these ureteric jets, we have started looking at these jets in chyluria on a color Doppler, and we are trying to evaluate the direction and the the characteristics of these jets, and maybe in future we come out with some information about this. Would be a non-invasive way of lateralizing the chyluria, because the characteristic of jet from normal side and from chylous side will be different. We hope to see in a non-invasive manner which side it is coming. The next step is, having said that it is from the left side or right side, you have to now know that where is the lymphatico-urinary communication. It is in the ureter, it is in the pelvis, or is it in the calyceal system? In earlier days, the intravenous urogram was done to demonstrate the lymphatico-urinary communication. And IUP was done with the abdominal binder on the patient so that there is a high pressure in the urinary system, and what would demonstrate the communication. But then we found that IVP is not a good test to demonstrate this communication, and therefore we abandoned this test, and we found that IVP is not necessary. This is published in 1992, long time year back. In fact, today, retrograde pyrography is a standard test for diagnosis of chyluria. And we described a modification of retrograde pyrography. The modifications that we made were that, first of all, the patient was put in Trendelenburg tilt position on the OT table, head down. And then the installation of contrast was not with injection, but it was installation, slowly, very slowly. So the renal pelvis is not suddenly filled, it filled gradually. And this was with the intention of sudden high pressure in the pelvis and creating rupture. So we put in two aspects into this test, and we called this a modified retrograde pyrography. And this test was demonstrated to have prognostic value. As you will see in this video, on the right side, a ureteric catheter has been placed and contrast is slowly instilled. And as the contrast is instilled and patient in the Trendelenburg tilt, the contrast starts going into the lymphatic passages on the medial side of the pelvis. You can create such pictures by retrograde pyelogram where you will see the pelvis and you see a lot of leakage in the lymphatics around the kidney. You can actually take X-ray films, and in X-ray films we have seen all varieties of lymphatico-urinary fistula. Somewhere from the fornices, somewhere from the infundibular area. In some patients, they are bullous, varicose kind of lymphatic channels. In some patients, there are tubular kind of lymphatic channels going. up there, going down there on the ureter. You need to take an X-ray picture of not only from the side where you will see such extensive lymphatic communication as in this picture, but the lymphatic can be seen on the other side, as you can see here, or in this film. You will see small bullous lymphatic-urinary fissures communication, and then you would see contrast going even into the thoracic duct. So the length of the fistulous communication, the caliber of fistulous communication, the tubular or varicose bullous, they're all shades of lymphaticopelvic fistulae seen by us and described in literature. As I mentioned earlier, in some of the patients when we did retrograde ureterogram, we found that the contrast has gone, filled the pelvis, and there is no fistulous communication visible. And patient was having pretty severe chyluria from this side. This probably happens because of valvular kind of communication which have oblique holes in the renal pelvic system. When you inject contrast does not go in them. And I said that the modified retrograde pyelography of this type has prognostic value. If you demonstrate pyelolymphatic fistulous communication, the severity instillation therapy that you do in these patients shows you rewarding results, because silver will go in the fistulous communication and then only it will sclerose those fistulous communications, right? In those patients where there is no pyelolymphatic fistula, and if you do retrograde instillation of silver nitrate or betadine, these patients do not respond well. And there is logic to it, because the X-ray picture is not showing a fistulous communication. Where will the betadine enter? Where will the silver nitrate enter? And therefore, these patients are poor responder to instillation sclerotherapy. So that's what I said. Our modified retrography technique has prognostic implications also. And this is the picture. Severe chyluria, and it is all clear. So we presented this experience in World Congress of Endourology in 1995 in Jerusalem, Israel, about all this data. Then there is another test mentioned in the literature, and I have not needed to do this, and I have no experience of doing this test, lymphangiography or lymphoscintigraphy. These tests are expensive, they're not universally available, they consume a lot of time. The image quality that you get is, something like this, which is very vague. So I think in the current era of good radio imaging methods, both these tests have no value. We have now described a new method for doing RGP, retrograde pyelogram, and this is by MRI. In MRI, when you put ureteric catheter, we inject 1 ml of gadolinium in the renal pelvis via the ureteric catheter and then collect the images. We will notice that this gadolinium is going into lymphatic spaces and showing the fistulous communication so nicely. And this is radiation-free test. So this has value where you don't want to give radiation to the patient, you can do this test. And it's a fairly good test. And we do this test in our institution very often. And this has been published about 10 years back. You can access this article by scanning this code. So that's about how do you make diagnosis of various aspects of chyluria. In my next video, which is part 4, I talk to you about how to treat this disease. So thank you very much for now. And in case you have any questions or comments, you can write on my email to me. Thank you.